All right, let's dive right in. Today, we're tackling a really tough topic, invasive aspergillosis. This is one of those opportunistic fungal infections that for clinicians is absolutely critical to understand. Why? Because mastering its diagnosis and its evolving treatments can literally be a matter of life and death for our patients. So let's get into it.
Here's our game plan for this explainer. We'll start with the big picture overview of the disease itself. Then we'll get into the nitty-gritty of diagnosis, how we actually find this fungus. From there, we'll talk pathogens and the growing problem of resistance, cover the latest treatment strategies, and then zero in on some particularly high-risk groups and complications. We'll wrap it all up with a mini lecture and a quick clinical challenge to test your knowledge.
Okay, first up, a general overview of the disease. The key word here, and you'll hear me say it a lot, is opportunistic. Invasive aspergillosis doesn't just infect anyone. It's a pathogen that waits for a moment of weakness, specifically a compromised immune system. And that makes it a huge threat across so many different clinical settings.
So what is it exactly? Well, Aspergillus spores are literally everywhere in the air we breathe. For you and me, they're harmless. But for someone who is immunocompromised, inhaling these spores is a totally different story. Inside their lungs, those spores can germinate, grow, and actually start to invade tissue. And that jump from simple colonization to active invasion is what defines this disease and makes it so dangerous.
So who exactly are we talking about when we say immunocompromised? Well, the guidelines are pretty clear on the highest risk groups. You've got your classic risk factors, like patients with hematological cancers or those who've had a stem cell transplant, but the list is broader than that. Think about any patient with a long ICU stay, especially if they're on corticosteroids, say for a severe COPD exacerbation. We're also seeing it more with severe influenza. And then there's a specific genetic condition, chronic granulomatous disease, where patients are uniquely vulnerable.
All right, let's move on to diagnosis. Finding this fungus is tricky. There's no single magic bullet test here. Getting to a diagnosis is really more like detective work. It requires a multimodal approach where you're putting together clues from the patient's clinical picture, what you see on imaging, and of course, what you find in the lab.
So, what does that diagnostic pathway look like in practice? It all starts with a high degree of clinical suspicion in one of those at-risk patients we just talked about. That suspicion should immediately trigger a high-resolution CT scan of the chest. If that scan shows something suspicious, like nodules or cavities, your very next move is to get a respiratory sample. And the gold standard procedure for that is a bronchoalveolar lavage, or BAL.
That BAL sample is really the cornerstone of your entire diagnosis. It's so important that you get the most out of it. To do that, the guidelines are firm. You have to send that fluid for both a fungal culture and a galactomannan antigen test. Why both? Because culture gives you a living organism you can test for drug resistance. But the galactomannan test can detect the fungus's fingerprints, its cell wall components, even if the fungus itself won't grow in the lab.
Now, you can run that galactomannan test on either blood serum or the BL fluid, and it's absolutely critical to know when to use which. The serum test is mainly a screening tool, really only useful for certain high-risk hematology patients. And you have to be aware of its major blind spot. In patients with CGD, its sensitivity is terrible, less than 20%. So for any suspected lung infection, the BL fluid test is what you want. It has a much higher diagnostic yield and is the recommended test for confirming the disease.
Okay, let's pivot to the pathogen itself. Because once you've found it, you need to know what you're up against. And Aspergillus isn't just one single thing. We're dealing with different species that behave differently. And on top of all that, we're facing a really scary, evolving threat: antifungal resistance.
Knowing the exact species of Aspergillus is a huge deal for treatment. Aspergillus fumigatus is the one we see most often, but if your lab report comes back with Aspergillus terreus, that's a massive red flag. Why? Because A. terreus is naturally, intrinsically resistant to amphotericin B. It seems it just never got the memo about one of our main antifungal drugs. This means you have to use a completely different treatment plan right from the start.
So you have natural resistance in some species, but what's even more concerning is acquired resistance.
And as this guideline from a few years back pointed out, resistance to our first-line drugs, the azoles, in the most common species, A. fumigatus, has been rising and rising fast.
Just how fast? How big is the problem? Well, to put a number on it, a major surveillance study in the Netherlands back in 2016 found that the rate of acquired azole resistance was already at 12.9%. That means more than 1 in 10 isolates were already resistant to our go-to drugs. This isn't some far-off threat. It's a real-world clinical challenge that we have to deal with right now.
So, that brings us to treatment. Given this landscape of different species and rising resistance, what's in our antifungal toolbox? How do we choose the right weapon for the fight? Well, the choice is heavily guided by clinical evidence and, increasingly, by local resistance data.
The approach recommended in the guidelines is tiered. For most patients, you're going to start with the azole, voriconazole. That's your first line. But if a patient can't tolerate azoles, or, and this is the big one, if you know you're dealing with an azole-resistant strain, you have to switch. The go-to agent in that case is liposomal amphotericin B. And let me be clear, this isn't just a suggestion. That switch is mandatory if you want to effectively treat the infection.
Now here's a really important point for anyone treating kids. The guidelines we've been referencing don't actually give specific dosing for pediatric patients. This is a huge gap. It means that if you're managing invasive aspergillosis in a child, you absolutely have to get a pediatric infectious disease specialist involved. It's non-negotiable. So let's just quickly recap the main principles of treatment. First, this is not a short course of antibiotics. Therapy is long, usually lasting at least 6 to 12 weeks, sometimes longer. Second, how long you treat isn't a fixed number. It's guided by how the patient is doing clinically, if their scans are improving, and if you're clearing the fungus. And finally, this is a team sport. You should always be working with an infectious disease specialist or a medical microbiologist. They're invaluable for navigating treatment choices, interpreting test results, and advising on any local reporting or infection control policies.
All right, let's zoom in now on a couple of specific high-risk scenarios. These are situations where invasive aspergillosis isn't just some secondary complication. It is the primary driver of a patient's outcome.
And the first one is in patients with chronic granulomatous disease, or CGD. The impact here is just devastating. If you look at the data, one landmark study that followed patients over 4 decades found that invasive aspergillosis was the single biggest cause of death in this population. It really drives home just how incredibly vulnerable these patients are.
The second key scenario, and one that's getting a lot more attention, is influenza-associated pulmonary aspergillosis, or IAPA. This is a really dangerous co-infection that can pop up in patients who are in the hospital with severe flu. And here's the scary part. It often happens in people who don't have any of those classic risk factors we talked about. It seems that severe influenza itself can disrupt the immune system just enough to let Aspergillus get a foothold and invade.
Because of this, you have to have an incredibly high index of suspicion. If you have a patient in the ICU with severe flu and they suddenly take a turn for the worse, or you see new spots on their chest imaging, IAPA needs to jump to the top of your list of possibilities. You have to investigate it, and you have to do it urgently.
Okay, let's wrap things up by putting all this information into practice. It's time for our mini lecture and a clinical challenge.
So here's the scenario. You're covering the ICU. You have a patient with severe influenza who's also on corticosteroids. All of a sudden, their breathing gets worse and they're in respiratory failure. You get a stat HRCT scan and it comes back showing new nodules in the lungs. So what's your #1 suspected diagnosis and what is your immediate next step? Go ahead and take a second to think it through.
All right, you got it? The most likely diagnosis here, given the severe flu and steroids, is influenza-associated pulmonary aspergillosis, IAPA. Your next diagnostic step is to arrange for a ball to send for culture and galactomannan. But here's the crucial management step. You don't wait for those results. The mortality for IAPA is so high that you should strongly consider starting empiric antifungal therapy right away, likely with liposomal amphotericin B, while you wait for that definitive diagnosis. And that leaves us with one final, forward-looking question for you to chew on. We know azole resistance is on the rise, hitting nearly 13% in some areas. So the big debate now is this. Should we be moving towards using combination antifungal therapy right from the start for all suspected cases of invasive aspergillosis, just to make sure we're covering those resistant bugs? It's a complex question with no easy answer. Thanks so much for joining this explainer.